Hey everybody, Dr. Rob Silverman here. We're doing Memorex. I got the wonderful, esteemed colleague, Dr. Brandon Steele. How are you, Dr. Steele?
Thanks for having me. It's been tough not seeing you out on the road lately, so we got to meet like this.
Yeah, I know. It's unfortunate, but when we catch up, we're definitely going to have an organic coffee. We're going to talk about the biomechanics of the L4, L5 region, and we're definitely going to come back. And I'm going to learn something from you because every time I either read something, watch something, or speak to you, I learn some really, really salient points about chiropractic and healthcare.
Well, thanks for bringing that up. And I gave you some questions and things that I wanted to cover, but what I didn't give you were the questions I'm going to ask you. So I'm excited to hear your answers.
Oh, goodness gracious. I'm happy that it's recorded because maybe we can always press erase. But you know what? I've got this great bio of yours, and I always like everybody to introduce themselves to the crowd and everything. We had talked about 16, 18 months ago. So why don't you give a little background on yourself?
Just a practicing chiropractor, and I'm in the St. Louis area. So I practice in Illinois, but I'm actually live in St. Louis and right outside of St. Louis. And I've been practicing here for a while. I used to work with some professional athletes and kind of got out of that game and went back into just the normal demographics that every chiropractor sees. And it's been exciting. I joined a couple colleges and I teach for those. And I kind of speak around the nation on certain orthopedic conditions. And I tell you what, the more I teach about orthopedics, the more I realize that orthopedics is one small little bucket that we can treat. And there's a lot of other things that we can treat, including nutrition, as far as rehab, just patient advice, education. And it's been exciting. It's been exciting to bring back new information to my patients, and then also take that and we have a software that we put it in and try to make it easier for people to practice.
You really do. And I want to bring up, you started Chiro Up, and I'm a member, and I get the blogs every week, and I really, I utilize them. They're so cutting edge. You do things for chiropractic and healthcare that many other practitioners don't do. I literally read yours every Sunday morning and go to the citations and start making slides for my presentation. So a lot of people are seeing Dr. Steele and your partner in my presentations every week. And I really appreciate that. And I'd like everybody to know where they can get that. And is it just for docs, or can the public also utilize it?
Well, the public utilizes it more than us, but a different platform. So the doctors utilize it as far as the information, then obviously we give it to the public as patients. So we put out about 40,000 reports per month. So we're making a pretty big impact on what chiropractors can do and how they're educating their patients. But before I got into chiropractic, I did a year and I was getting my PhD in microbiology and immunology, and I read research every single day. And I loved research. I loved performing research. I loved reading research. And then quickly I realized that nobody else did. And you take all this cool information that's coming out within a month, within a year, but it never goes anywhere. Only the people who like to read research were looking at that information. And I thought it was just a huge disservice. So when I got into chiropractic, I realized there's a lot of good information out there. Not everything we have to do has to be research-based, but it should at least be research-informed. And so that's what we did. We set out to look at all the articles that are coming out this month and to turn them into usable formats. If it's a new exercise, if it's a new piece of information on exercise or rehab or evaluation or treatment, turn it into something that people can use, whether it's the provider or the patient, depending on the information. And that's where Chiro Up was formed. It's just it's a knowledge transfer system and how to get that information from the research to the patient, easy and seamless.
It's outstanding. It is a great go-to source. So for any chiros that are watching, or PTs for that matter, manual practitioners, I'd strongly recommend it. I mean, I truly endorse it. I mean, I look forward to those Sunday morning blogs, and you either have a blog, with a video. Sometimes you have like a research review for the month, which is excellent. And for some of us, or many of us, who are so in line with practice and we don't get enough time to actually read or subscribe, is a great an epigrammatic way of catching up for the week.
Yes, and well, thank you for the plug there. And we just enjoy doing it. I have a blast doing it. We've got a great group of people who enjoy doing it. And it is a company, but it's more of a passion, and it's something that we just we love putting on. We love getting the feedback on what we can do next.
Great. Well, we have chiros that'll be listening. They'll probably be asking some questions. So at the end, we'll let them know how they can get in touch. We'll put it in the comment section. We were going to talk about pain. We were calling this Overcome the Invisible Disability of Chronic Pain. So for all those out there who want the headline, it's we want to stop the pain. Now, we may not look at the site of injury, knowing you, but we're going to stop the pain. So tell me, chronic pain is a big part of a lot of the chiropractic clinics. Why is it so difficult to treat these patients?
And that's the cool part about this presentation that I was putting together about a year ago, and it kept on changing over and over again because I looked at all the different people that I know who are crushing it in our profession and other professions, and they have a solution. So their solution is nutrition, or their solution is chiropractic manipulation, or what have you. And then they take that one solution, that one method, and then they try to solve every problem with that one solution. And I thought that's just ass backwards. It doesn't make any sense that we have a problem, and the problem in this case being pain. There have to be multiple solutions. And it's really about deciding which patient needs the right solution at what time. And that's where the fun of practice really comes in is this truly a peripheral problem? Is it just being wound up in the spinal cord? Or is it maybe a perception problem in the brain? And the cool part about that is when you kind of understand how pain works, as we all learn in school, then it's deciding which aspect you want to work on in your clinic, and which I think is the biggest disservice to our profession. It's understanding when you're not the right solution. And to say, you know what, they need manipulation, they need myofascial release, and they need exercise, but they also need to see a nutritionist or a psychologist, or they need to get a spinal cord stimulator. So finding all those different pieces of the puzzle and then building in a referral network of people around you who understand that same process is how many of the chiropractors are building their practice today. And that's the exciting part about pain, is that there's multiple solutions to the same problem and each one works. It's just about defining that recipe for each person.
That's right. The individualizing your treatment for the person, not a just an equation. Too many times we lecture and too many docs ask us, and understandably, hey, what's the protocol? What's the recipe?
Yeah, I get that a lot.
Yeah.
The reason that brought me into this discussion is I don't like chronic pain patients because of the time part of it, and I like building relationships with patients. But and you've probably, I'll bring this patient up, and you'll know exactly the patient that fit into your practice this week. But I call them checkmark patients. So they come in and their pain is a 10 out of 10. And then they see you, it doesn't matter what the pain is. It could be headaches that are severe, unrelenting sciatica. They come the next day and their pain's all the way to 0. And they've had pain for 10 years and they saw you once and now they're magically better. You know damn well what's going to happen to that patient the next time you see them. They're going to be way up here again. So they go to this check mark, and I start to think, why is that happening? And I don't think it's a mechanical model, because degenerative tissue, muscle hypertonicity, neuropathic pain doesn't go away in a visit. I know that. Every chiro, every manual medicine doctor knows that. So I started to think there had to be more to that puzzle, to that checkmark patient. And I think it's the hope, it's the perception that you know what you're talking about and that you're going to help them. And so I know there's more to pain than just bones pushing on nerves. I think it has to do with a chain, like I was talking about, looking at the first order neuron as far as the periphery, the second order neuron in the spinal thalamic tract, and then looking at what happens in the thalamus and above, and then deciding how dysfunctional that person is.
I love the analogy of the check mark. I just had a check mark patient call today, 16 years. I was like, man, I've got to call all the chiros I know. I must be the best chiro in the world because that last treatment lasted you 16 years. So that check mark went here and it went through the roof. They hit the capstone, if you will. And if we can share something with patients, don't let pain just be the driver, and please don't wait 2, 3, 16 years for your next chiropractic assessment. So many people wait till it hurts, or then they decide to see a chiro. And we always use the idea of like a dentist, the alignment and the cleaning and an evaluation. I go every 3 months because I've got gingivitis. Chiros should come in periodically to get checked, because not only are you checking for injury or for pain, you're also checking for wellness. You're also checking for care. Now, with the idea of pain, I've got a video that your partner made talking about a disc injury.
Mhm.
And it is one of the best videos I have. I show all my patients that, and I say to them, there's no pressure typically from the disc material because of the consistency of the disc. And it's more of a leaky faucet, or I always tell everybody, we kind of made the mistake that we said that a disc was gel. It's only 20% gel. The rest is liquid. So it's kind of like a warm milk. Could you kind of go into detail, because you talked about the dorsal neurons and everything like that, and really illuminate people to the idea of a disc, because everybody comes in and is scared of a disc herniation and think disc herniation and word association means surgery.
Yeah, so a couple questions in there, and that is a really good video. And if no one's seen that video, it's on non-Newtonian fluids, so a fluid, and if you move it around and you can actually mold it, it falls between your fingers. However, if you put a lot of load through a non-Newtonian fluid, it'll become hard as a rock. And that's what your disc does. You move around, it's completely fine. But if you put shock into it, if you were going to fall on your rear end and maybe it's a 70-year-old, what happens? Well, it fractures the bone above it. Tissues in our body actually learn to adapt based on what we do. And that's really the process of the learning aspect of the wellness care, is that we're learning about what that patient's going through. So I look at it as I'm trying to learn how their body is adapting to that pain. So in your example of a disc problem, what's happening to that patient? Where is that physiologic learning happening? So the periphery, so what's happening to the body? Well, their body's learning that if they have sciatic root tension, to maybe not extend their knee. So what's going to happen to their knee? They're going to learn that if they can't sit in the recliner because their leg's straight in the straight leg raise, so they sit in a different kind of chair. They learn that they don't want to pick up their grandkids because loading it is now causing their problem to become more sedentary. So those are the things that I think fit so well into our profession, because we can look at the musculoskeletal, the outward projections of that disc herniation, to find out psychologically what's happening in musculoskeletal, what's happening to that patient. And then we can look at the actual dorsal horn. You can look at, what's happening at that second order neuron. Now they're not going outside because of that pain. They don't get that descending inhibition from the, from the spinal cord. They're not from the brainstem. And they're not getting everything that exercise induces, so they're becoming more sedentary, and they're sending more signals up to the brain. And now their brain's getting more and more signals winding up, and they're getting now referred pain somewhere else. So this one isolated problem as far as the disc, yes, we can help with that, and their body's going to fix that regardless. But it's all the things they've learned to do because of that long-standing pain that I think we can also have an insertion point into. And we could say, that disc herniation is going to heal. Yeah, we can do a discectomy. Yes, we can do a kyphoplasty for that compression fracture, but let's work on the things that are going to cause the long-term dysfunction, which are those three different areas of physiologic learning.
So you kind of went into my next questions. How can chiros, since we're doing a chiropractic laden conversation, treat that peripheral pain? That was one example. Can you take it a few steps further?
Manipulation solves everything. I think, in all honesty, and I really do believe this, and a lot of people don't necessarily like when I say this, but I think one of the faults of chiropractic is that manipulation works so well. And because I know I get lazy. It's Friday afternoon here. I get kind of lazy towards the end of the day, and I'll be damned if manipulation doesn't work, get people in and out of pain fast and get them moving better, and it meets their goals. So unfortunately, manipulation works so well to help decrease that peripheral sensitization, getting tissues to relax, taking that tissue and increasing the pain sensitivity, or using our manual therapy to help stop those pro-inflammatory cytokines. We can use nutrition to hopefully decrease some of the inflammation, stop a bunch of those prostaglandins from baiting that first order neuron. So there's a lot of things that we can do as far as chiropractors. And I think that's where a lot of people stop. They look at, the pain hurts at your thumb, so they do everything they know to the thumb. But we also have to think about what's happening, along that chain, and where we can also make an impact. And I think that sometimes people will lean on their education to understand all the things that they can do for that one isolated lesion. But what I would recommend, which the allopathic profession has done so well, is have other people, have other experts who are great at those things. Like nutrition, I would rather change your religion than your diet. I, I'm I'm not good at it. I don't enjoy talking to people about their diet, but there's someone down the street, another chiro, who's functional medicine, who I send everybody to, that they can make that impact and they can help in their own realm. And I think that current model of healthcare, where we're currently getting paid based on our education, is really the wrong way of looking at it. We need to look at all the sites of dysfunction and then determine who's the best person to treat those sites of dysfunction.
Yeah, so you're clearly integrated as myself. We believe in a full team and a composite team, and we like to stick with, as Warren Buffett says, circle of confidence.
One of the things that I start my lectures off is that, who, by a show of hands, who here thinks that epidural steroid injections help? And you might get one person or two chiros that'll raise their hand. I'm like, that's crap. They work all the time. The thing is that when you have a therapy that works, guess what you don't do? You don't go back to the practitioners. Oh, yeah, that worked really well. You just don't go back. And the same thing happens with us, that when someone sees us and manipulation or myofascial release didn't help, guess who they see? They go to their pain management doctor. So all we do is trade each other's failures back and forth. And if we each, if all of us had a little bit of humility built in and say, you know what, I'm going to do this and this, I'm going to send you to the psychologist and the pain management doctor, and build that team of what you're good at and maybe what you're not good at. And selfishly, that's how I've built a network of people who trust that I'm really looking out for my patients' best needs and their patients' best needs. And it's been very successful for us.
It's very funny. When I graduated school 20 something years ago, I asked a chiro that I had a lot of respect for to piggyback on what you're saying. And I asked him, how do I build a practice? And he said, well, it's a fourfold attempt. Number one, keep your overhead low. Number two, treat every patient like you would with your mom. Number three, answer the phone once in a while. And it's funny that you said number four, and it was a real takeaway. He was like, know what you know what you don't know, but you'll get the most referrals you'll get is from people that you referred out to another good practitioner, because they will trust you.
I'm writing that down now.
There you go. I mean, that was it. Keep your overhead low, treat everybody like your mom, find your niche and market it. And don't be afraid to refer to somebody who knows it, because that patient will trust you. Because the biggest question sometimes on chiros or the knock is, once you go, you keep going, which is ludicrous. So got another question for you. How would you tell chiropractors, and this is an expansive answer, to treat pain propagating within the spine? Because all chiros start with everything in the spine, and then we ventured out from there.
Yeah, and I think that the hardest part about that question is that most people think of the spine as within the cord, and I'm thinking, that's what we're good at. But I consider that peripheral pain, even when it's coming from the spine. It's not until it actually gets within the dorsal horn and makes that synapse, the second order neuron, and starts to go into the spinal thalamic tract, that I really get excited, because there are things that we can do within the spinal cord, which we don't really think about, maybe as much. But whenever you have that, any kind of exercise, or there's something, I think they're called opioids, and they do a really good job. And people get on my case about that all the time also. But I had a surgery about 2 years ago that had me down and out, and I took some opioids, and they were phenomenal. They were great, and by no means are they a long-term solution. However, what do? They take away pain. So there's other things that are a little safer, obviously, for long-term, like our CBD oils. But exercise is great to stimulate the descending inhibitory pathway, but taking advantage of those pathways. And so many chiros that I see aren't doing rehab. They're not looking at their patients move. They're not helping their patients get out of bed easier. They're not giving them the patient education to get them up and moving. And today, with the pandemic, I'm seeing a whole different set of issues with people being sedentary. So it's really about finding ways to stimulate that endogenous system in a healthy way, of course. I think that'll go a long way. And we're seeing that with the research coming out, is that we really have to be doing that from the top down, as far as convincing them, being that intrinsic motivator to say, listen, Bob, we need to get you out and moving. In fact, I know you have knee pain, but I need you walking for 20 minutes a day, because what we know is if we can just get that joint moving, then we're going to have an impact over and above the typical manipulation and myofascial release and exercise that we normally do.
Absolutely. So I'm curious, in your practice, what would you say the top 5 things that you see? So I always get that question from the new chiro, the new practitioner. So I'm going to give him your answer for the next year.
I have an odd group of people. So I see a lot of TMD patients, just because I know a lot of dentists in the area. So that's kind of, it is what it is. I have a lot of runners. And by runners, I don't want to say that I treat Achilles tendinopathy or tarsal tunnel syndrome or plantar fasciitis, because they're all kind of different. But I would say lower extremity issues and TMD are probably my focus. Which is funny, because when I teach, I almost always work on the neck and the shoulder. So I do a lot of shoulder stuff, but I just don't see a lot of those patients for whatever reason. I have, most of my network is built in off runners and jaw pain. But it is what it is. I guess if you help one person, they talk. And as soon as you get known in a certain circle, you kind of build your network within that circle. I'm sure you get a lot of the same things. I do have a question for you, though. So is there a recipe? Is there a simple way to decrease inflammation in the body? Not a very focused approach, but kind of like taking 5 ibuprofen, which is a shotgun approach, taking a steroid dose pack. That's a shotgun approach, just to decrease inflammation. What is a safe, conservative prednisone? What does that cocktail look like as far as a supplement, as far as some kind of safe drug? What do you think?
Yeah, that's a great question. So I'm in Westchester County, so I'm 30 minutes outside the city. I'm in a medical building. I've got 3 physiatrists. So, and we refer back and forth. So somebody comes in and goes, I'm not buying that. I want the shot, or I want this. They have that option right there. So I'll talk from more of an alternative perspective. So
Yeah.
here's some of the things that I would say, hey, I want to decrease your pain. And you know what? I believe that a chiropractor's job, one of our mantras should be to manage and modulate inflammation. If we can do that, we can get the kind of clinical outcome, because if you can't manage the inflammation, I mean, that's what this cytokine storm is all about. Our body can't manage inflammation. And that's an immune system issue. And there's other reasons in musculoskeletal. So a few of the things are dietary triggers. I'm a big believer in get the trigger out. So chiropractic is, you know what, if you're bending at your lumbar spine and you're not hip hinging, I got to teach you how to move well, because otherwise I'm never going to get any resolution in L4, L5.
Sure.
So it's one of those. So triggers. So triggers could be environmental toxins for pain. Playing with too much paper, working in the old newspaper factories, living by a highway. So a trigger. Many of the triggers, and the worst triggers, are foods. Now, we could do a whole podcast between the two of us, and it would take us 2 weeks to finish when we talk about foods. So the big ones are gluten, dairy, processed food, sugar, artificial sweeteners. So I take a lot of food triggers out. I take movement triggers out. And then, I'm not really sexy on the supplements that I give. I mean, I have a plethora to choose from, but when it comes to pain, believe it or not, I'm going to tell you turmeric, and somebody's going to say, thanks for the memo, Rob. I'm going to talk about omega-3 fatty acids. I'm going to talk about glucosamine and chondroitin. I'm going to talk about different pathways on upregulating the omega-3s and decreasing the omega-6s. So I'm going to talk about things that stop. So the big thing about nutrition, and the takeaway is, it's a very interesting term they call upstream and downstream. So what does that mean? So the way I tell a patient is, we're on top of a waterfall. If you take a drug, it works. Downstream, it lets the left and the right side not hit the water. It stops it. Now, there's a pro and an anti-inflammatory pathway. Downstream shuts everything off. So it's good for pain, but like you said, not good for a long period of time because there's no healing. Whereas nutraceuticals are upstream. They can manage and modulate the water. The only problem is it just takes a little longer to get to threshold. So again, it's nothing sexy, but it's a composite look at what we're doing as far as modalities. And we both use modalities. We adjust our patients, no doubt about it. We use soft tissue. I know you use instrument assisted soft tissue. I know you use myofascial release. You're big on exercise rehab, resetting the core after a lower back injury. I use a lot of laser. Not sure if you have one of those, but I know you have modalities because I know that you adhere to the same thing I do. You're not worried about what treatment works. You're just worried about the patient.
Yes. So I'm glad you brought that up, and I'd love to see a graphic of that. Is that something that you have in your presentations? A graphic of that? What I would, because you brought up the water faucet thing that we use as far as a PDF and pain. That'd be a great, powerful thing for other chiropractors to see, because I can picture it in my head, but I'd be curious to see what that actually looks like on paper from you. That'd be something that would be useful for a lot of chiropractors.
I'll tell you what, it's very funny. I just wrote a note. That's something I use as my evocative moment. I just wrote a note, and I'm going to get my graphic designer to do it, and I'll tell her what to do so it looks really good. And my wife is great, but she pastes the picture. I can't ask her to make the picture. So I'll have that. I'm going to get off. When we get off, I'm going to do it right now. And once I get it, it's yours.
I love it. Thank you so much for doing that.
Oh, no, my pleasure. So thanks for asking. And, it's great. What's great about these podcasts and what's great about these, recorded lives is the conversation with the guests and the back and forth and the give and take. And sometimes I almost don't want a subject matter and just get into talking. And it just works so well. But I did have a couple of questions. It never asked you, how does chronic pain start?
Yeah, I don't know.
Stumped you. Sorry about that.
Don't you hate that question from a patient, though? Doc, how'd this start? I'm like,
what is going away? Doc, right?
Yeah, I just met you 5 minutes ago. I have no idea what's going on. I think it's a collection of things. I think that so many people focus on one thing. I was bending over, brushing my teeth and spit, and my back went out. Well, it wasn't the weight of that toothbrush that caused your back to go out. It was all the precipitating things that led to that. And it was interesting that you brought up the decreasing the omega-6 and 9 and increasing the omega-3s. And I can still remember reading, I think was it Clinical Nutrition? Is that David Seaman's book?
That is, yeah.
I was in college when I first read that, and it's those kind of things. You're like, oh my God, I can't even think about all the years that I've been destroying my body with Pepsi and Pop-Tarts. But that's all you know. And so I think that all these things come to a certain point. And if you had to imagine filling up a bucket, and that's the capacity of a tissue, where the capacity is the outside part of the bucket, and then all the stressors that we put on that kind of go into that bucket. And it could be, picking up the grandkids. It could be maybe an imbalance in your diet, or maybe a new activity or working from home. All those things build up and then create this problem. And I used to think that, I provided a solution that start to empty some of that water back out, but really it's how much water can you empty out of that? Because if you only empty out a little bit, you just manipulate them and tell them not to pick up their grandkids, they're going to feel good for a little bit. And that's fine. That's why they came in to see you, but they're going to come back in a month, in 2 months when they do it again. So the greats, the great clinicians that I know are not the people who wrote books. The great clinicians, we measure outcomes on every single provider. We've got thousands of people around the world who we collect stats on. And it's so interesting because the greats, the people who are doing the best job, best patient satisfaction, best clinical results, I have never heard of before. You've never heard of them before. They're in South Africa. They are in Ireland. They are in Mississippi. And they don't write a book. They don't write a journal. They just go in every single day and empty water out of glasses. And that's what gets me excited, is because those people have figured out that, kind of like what you said, is that if it's your family member, you're going to dig a little deeper. You're going to find out all the potential triggers for that person. And you're going to step by step put a hierarchy on that and say, all right, today we're going to attack number 1 and 2 and 3, and then next week we're going to get 4, 5, and 6. And that's where I think the chronic pain comes in, that if we can identify all those triggers and we can have the ability within ourselves and our network to solve that, we're going to have a dramatic impact on the healthcare in the United States.
I agree. And it's funny that you say that. I'm definitely going to go here. So somebody always asks me, who's the guy in the room? And I'm like, I don't know. Meaning like, who's the smart guy? And they're like, when I lecture, they're like, you're always nice. Some lecturers do this. And I'm like, listen, I'm from New York. We know how to do that, but I know not to do it because there's some guy who's wearing a pair of jeans and a t-shirt and only cares about helping everybody and is not going to get up and tell you off. But man, I've learned so much from them. And, my hat's off to them because it's all about the outcome and it's not about everybody knowing their outcome.
Yep.
So it's sort of the antithesis in the world that we live in now. You're right. So I write books and, I do it for a different reason to get the message. And I've done the TV, and you're right. I mean, I probably shouldn't say this now, but as we go through COVID-19, there's a lot of TV docs, not functional medicine or chiropractors. They have their shows. Where are they now?
Yeah.
Right. But right, where are they now? We all hear about them every day. Did you hear about so-and-so saying vitamin C? And nowhere. The ones that we see are the guys, who have been kept in the shelf for 40 years, 10 years, 6 years, men and women. So I concur with you. It's funny. We didn't get to go live. We had a little technical difficulty. So remember I said it would be a DM? Hey, Doc, by the way, you're really late. I'm like, yeah, thanks. I'm really concerned. Could you ask Dr. Steele to talk about disc pathology, bulge, herniation, extrusion, and what it all means? So there's your question.
Yeah. I don't know if it matters that much, to be honest with you. When you look at the research, it matters to the patient, it matters to the insurance company, and it does play in my mind. Do I truly have, if I've got an extrusion, I've got something pushing on a nerve, and I've got neurologic loss, yes, I need to move them along that chain of referrals. However, if I don't have the actual loss of function, progressive neurologic loss, I don't have any kind of other red flags, I don't know if it matters that much if it's a small disc bulge versus a protrusion versus really a herniation. If they're making improvements in my office, I'm not going to get too excited. The one thing that I will say is that there are some patients who don't, in the case of maybe a radicular symptom, if they're not centralizing quickly, regardless of the pathology, I may call in help. I may say, hey, this nerve is pretty flared up and irritated. I'm going to go ahead and call in some help from another provider. But when it comes to the research that I know of, I don't know if it really makes a difference, because what we know is disc pathology has no impact on the severity of pain. We know disc pathology is going to get better as far as, it's just going to slowly degenerate and create degeneration around that area. So I'm not sure that it's not that I don't care, and I don't want to come off sounding, naive, but I've seen some grenades go off in the back upon X-ray and MRI, and the person is asymptomatic. So I treat it as a piece of information, but I don't get too excited about it. And I don't want to say that degeneration is a natural part of life. I understand that it is, but I don't want to belittle the patient when I say, oh, we got this horrible disc bulge. I think that's really bad. But I think it's also bad to say, oh, we've got a disc bulge, oh, don't worry about it. Because I think both can come back and hurt you. But I think as long as in your patient education, you say, listen, Bob, you've got a disc protrusion. There's a chance that's what's causing the irritation going on the leg, but here's what I'm going to do. So I address the problem, I address the structural issue, and then I still go upon my clinical findings and my orthopedic exam to do what I know how to do, and hopefully it helps. But as far as grading it and different types of modic changes, while I understand we need that for research, it doesn't play a lot into my thought process and how I'm going to treat that patient.
It's funny you say that because do you have a patient ever came in and said, I need an MRI?
Yeah.
When are you going to get one? I need that.
Yeah. I ask them, who's your lawyer?
I need that and I always ask them, and I'm sure you do something like that. If not, you can steal it. It's like, okay, your MRI is going to say that you have a disc pathology, probably a disc herniation, certainly a disc bulge. Tell me what that means. Well, I don't know. So again, I had this conversation with a patient. You're telling me what you think you need, and I want to please you, and I want to help you, but you've never driven this ship before. So how about, you're paying for my opinion. Why don't you at least hear it?
Sure. Yeah, it's all about goals and what they're looking for. And then I always tell people, listen, if I need to get an injection, I need to send you to surgery, I need advanced imaging. Do you want surgery? No. Do you want a big needle stuck in your back? No. Well, then we have no need for an MRI right now, as long as there's no red flags or anything else, concerning
Sure.
our trauma. But yeah, you don't want to put people in their place, but you also want to educate them on you're looking out for their best interest. I'm not looking to, in that case, I'm not looking to spend their money on something they really don't need.
All right. So here's the big question. This guy knows I just texted him back. So if you see me looking down, I'm actually, people are DMing, where is Dr. Steele? And I'm like, don't worry, he will be Memorex. They wanted to know your 3 top lower back exercises that you would recommend. Those that are without question, non-starters, no buenos. And we'll go with that. So your 3 rehab exercises that are yes, and your 3 things that they do that just make you grind your teeth.
So I don't have an answer to that, but I do have I think a better answer. So top 3 exercises is always dependent on the diagnosis. I mean, I'm going to give them the right set of exercise for the right diagnosis. And I'm a big into directional therapy. I think Mackenzie does a really good job on a couple aspects of what we do as providers. So looking at the stats of the conditions that I put out through my clinic, lumbar spine extension exercises for disc problems are going to be my number 1 as far as for that diagnosis. You normally hear about press-ups, as far as laying on your belly, doing like a cobra, as far as like a yoga move. But I've actually modified that, and I do a wall extension. So I had them put their elbows on a wall, kind of like a floor plank, but they're leaning on a wall, and then letting their hips sink into the wall. It allows gravity to be on spine, but also allows them to kind of take some of their body weight and put it on the wall. So that's my number 1 low back exercise. I do diagnose a lot of disc problems, and I don't want to qualify that. That's mostly because I get my referrals from a pain management doctor. So that's a skewed demographic of patient intake. As far as just a general low back patient coming in who's younger, I don't even do stretches. I'm a strengthening kind of guy. So I teach the hip hinge, and we go straight into lunges. A posterior lunge as far as going backward, just working the glutes. Getting them to perfect that movement. So that's probably my number 1 and number 2. As far as an older population, my number 1 exercise is a standing knee to chest. So we all know a knee to chest, laying on your back, but putting your foot up on an elevated surface and actually bending down and pulling your body down towards the floor. It adds gravity, it adds a lot of torque to the back. It opens up the neuroforamen, and it's just a good stretch. So I see a lot of patients who benefit from that. And of course, I can make them harder or easier based on the patient, but those are my top 3 per demographic.
Excellent, excellent. So I'll give you one that I kind of don't like. Sort of drives me crazy. It's going to cause me to have hair loss. Sit-ups.
But someone's got to just, laugh at the people who come in and they're doing the exact opposite of what they should be doing. And that's the unfortunate part, because I don't know how my dad is 66. He still has the same notebook of exercises he did 30 years ago. And he still does the same stuff over and over again. My dad's a smart guy, great person, but he still looks to what he knew back then as to what he still knows now. And I think that the beauty of what we do is we can provide new information to the patients to hopefully break those stereotypes and get them to move forward in their diagnosis.
Yeah, I'll give you another one. Are you ready? Crunches.
Love them. Yeah, crunches all day long.
Yeah, good. I always tell everybody, sit-ups and crunches, good for me, bad for you.
Exactly. Yeah,
Yeah.
I'm surprised the chiropractic profession doesn't pay royalties to CrossFit. I think that we should really start that process. They help us out a lot.
Yeah, when people doing sit-ups and crunches,
Yeah.
absolutely. So, we're winding down. I had a couple other questions. What strategies would you recommend to use to affect your perception of pain, the perception of pain now, by your patients and the other docs listening patients?
Perception of pain is probably my number 1. So before I even look at the body and before I determine their goals or, let them figure out what they want me to do. Let's say it's a shoulder pain patient and they have pain in their shoulder every time they've got impingement. They go to pick up their arm at 90 degrees, it starts to cause pain, and they stop doing that. And going back to that same patient, they stop picking up their grand shoulder and they stop doing, they stop working on their computer mouse. And I think that's probably the biggest piece of this is we have a pain that's peripheral and now it's starting to manifest in the brain, and they stop doing the things they love because of that pain. So the number 1 thing that I do is get them to do whatever it is they can't do. and hopefully within the first visit. So, in that case of the shoulder, teaching them how to move their shoulder blade with a scapular assistance or retraction test, teaching them how to externally rotate their hand as they pick their arm up so they can clear that greater tuberosity from the acromion. So finding different strategies to make sure they can do that activity day one. Meaning if you can't get up from a seated position, we're going to find a strategy to get you up from a seated position without pain. And that should be done immediately, regrouping those motor patterns, because I think that's what's the leading cause of disability that we have in the population is people that can't get off the floor. People can't get out of their truck. They can't go to the doctor's office because their foot hurts too bad. That if we can remove those pieces of disability, which is a mental game a lot of times, then we can have the greatest impact on our patients. And often that leads to that checkmark patient. It builds a little bit of confidence. Oh, well, if I just do this, now I can pick my arm up to here. This guy must know what he's talking about. So I would say before you get into which tissue was injured, before you get into advanced imaging and all that kind of stuff, just figure out what the patient wants to do and what they can't do right now, and make sure your strategy involves solving that problem.
That's great. So you have any key takeaways that you want everybody to remember you by in this episode by?
Key things to, you know what, I'm going to steal this one from Annie O'Connor. Words matter. And to really think about all the things that you tell your patients. I know this was 2 years ago. I removed the word pop and crack from my vocabulary for about 6 months. I didn't talk about it. I didn't talk about the manipulation. People stopped expecting pops and cracks. And of course, I love adjusting people. It gets me up in the morning. I mean, I love hearing pops and cracks, but people start to depend on what you say. So if the same thing that you talk about taking somebody off work, well, that matters. You have to get people, if you tell somebody to stop running, to stop squatting, to stop doing something, that information, kind of like with my dad, is going to carry him for the next 40 years. So really think about how you educate your patients, and really think about how you're going to rehab those patients. And don't do the same thing on every single patient. If you do the same thing on every single patient, and if I know you, I will find you and I will kick you in the shins, because it's a service. And to be honest with you, it's boring. It's boring as a provider if you just do the same thing. So find out what the patient needs and provide a recipe, provide a multimodal approach. Here's your patient education. Here's what I'm going to do to you. Here's the things you can do for yourself. Here's the supplements you can take. Here's the things that avoid with gluten and dairy and sugar. If you can do that for every single patient, develop that recipe, develop that plan, I think as a profession, we're going to be looked upon much, much more favorably, both from insurance companies, but really from the people who matter, which are the patients.
Absolutely. So how can they get in touch with you, and how can everybody get in touch with you via ChiroUp?
My email is Brandon, BRANDON @chiroup.com. It's just the website. So it's www.chiroup.com. We make it pretty simple. But, a little backstory, not to go too late, but, ChiroUp, everybody's heard the term cowboy up. And I'm a part of the Illinois Chiropractic Society. I'm a board member. I do a lot as far as legislation and working towards moving our profession in a projection forward. And one of the things that I got from the older people in my group was very much a lay down and die, lay down and bleed. Oh, this is happening to us. Oh, the sky is falling. That's crap. There has in even today's world with the pandemic, there's never been a better time. There has never been a better time to be a chiropractor than right now. And if you truly have access to the information, and you can truly synthesize that information as far as how well spinal manipulation and patient education and conservative measures are working, and you can deliver that to the medical doctors in your area, you can deliver it to your patients, and you can deliver it to Google as far as Google reviews, then it's really a good time to be a chiropractor.
I concur. I think it's our time, and I think that if we all take a step forward and let somebody like you lead the way, I think we'll be in a better place in 3, 6, and maybe 12 months. It's been my pleasure, Dr. Brandon Steele. We have to do this again. And I got a ton of notes over here and a slide to make, and I really appreciate your time. Hope to see you soon.
All right. Thank you for having me.